Good morning, everyone. Respected faculty, colleagues, and juniors. I would like to welcome you all to the 15th postgraduate clinical rounds. So we will be covering acute kidney injury part 2. We have already done the acute kidney injury part 1 PGCR. So we have covered all these topics. We have discussed the basic anatomy and pathophysiology of the kidneys. We have discussed the assessment of renal function, definitions and staging of AKI, impact of AKI, etiology, and the renal aspects in pregnancy. So in this talk, we will be covering AKI in specific scenarios such as AKI in cardiac diseases, AKI in liver dysfunction, AKI in obstruction, and contrast-associated AKI, and we will be discussing the basic management of AKI and a brief primer to the various diuretic modalities available for acute kidney injury. First of all, we'll have the acute kidney injury in cardiac disease talk by Dr. Akash, DM Resident from Department of Cardiology.
Thank you, Dr. Avril. Good morning to all esteemed faculty, my colleagues, juniors. So I'll be discussing brief on AKI in cardiac diseases. So heart and kidney shares a bidirectional nature. So what is the connecting link between the heart and kidney? That is the RAS system, that is renin-angiotensin activation system. So any disorder in which a heart is acute or chronically diseased can cause renal dysfunction, and a renal dysfunction in having acute and chronic can lead to disorders of heart. That is known as cardiorenal syndrome. Coming to the types of cardiorenal syndrome, we have divided into what is the primary organ involved and what is the duration of illness. If it is the acute cardiorenal, then it is in the settings of acute coronary syndrome, and if it is a chronic type 2, that is chronic heart failure, and if it is a chronic renocardiac syndrome, then it having settings of AKI first, and then it is a chronic renocardiac syndrome. And in the type 5 we have secondary CRS, that is both organs are involved, that can be acute and chronic both. Coming to the causes, we have some predisposing factors, that is diabetes, hypertension, obesity, anemia, and old age. Coming to the pre-renal causes, the most common is acute myocardial infarction, cardiomyopathy, heart failure, arrhythmias, pericardial tamponade, sepsis, etc. Coming to the renal causes, which affects the renal directly, that is drugs, most commonly NSAIDs, diuretics, over the time ACE inhibitors, and etc. And the contrast which we are using in the angiographies, in the CT coronary angiographies, and various imaging modalities, and vasculitis. Coming to the pathophysiology, if a acute cardiac insult happens in form of MI, cardiomyopathy, arrhythmia, we have, first of all, we'll have decreased cardiac output, which will tends to lead to decreased renal perfusion, which increase renal vascular resistance. Other mechanisms also happening in our body, that is neurohormonal activation, leading to activation of renin-angiotensin aldosterone system, leading to sympathetic system activation. Some inflammation is going on, leading to increased cytokine release and leading to salt and water retention, leading to AKI, that is decreased GFR, tubular toxicity, and decreased O2 to the renal cells, causing necrosis and apoptosis. Coming to the diagnosis, as we have already discussed before in the first PGCR, diagnosis based on cardiac biomarkers and renal biomarkers, biomarkers playing a crucial role in the establishing of the algorithm of the diagnosis of AKI. If renal is involved, then we have some biomarkers such as NGAL, TIM, cystatin C, which are used in renal dysfunction. And if a heart is diseased, then we have myoglobins, pro-BNPs, and etc. to diagnose. Non-invasive measures, we have 2D echo to assess whatever the condition of the heart is. So coming to the management, first thing first, we have to avoid and minimize the non-essential and nephrotoxic medications, as we all do. And the primary goal to ensure that optimal intravascular volume status, mean arterial pressure, cardiac output, and maintenance of the fluid and electrolyte balance. So first thing, if patient is having MI, then first thing we have to revascularize it as early as possible. So if the perfusion is reduced, so we'll straight away do the angiography, then followed by angioplasty and whatever the modalities are. And if the patient is in shock, then we'll straight away do the inotropic support and vasodilators. And if patient is having very low ejection fraction, having not able to pump enough blood to the body, and renal perfusion is hampered so severely, then some ventricular assisted devices we have in our settings, that is ECMO and tandem hearts, etc. And if patient is having arrhythmias, if patient having dilated cardiomyopathy, left bundle branch block, having severe LV dysfunction, then we can have straight away go for pacemakers also. We have resynchronized therapies also, which we can provide benefit to the patient if patient is having low ejection fraction, which LBBP. And if patient is having volume overload, first thing we all do is diuretics. If diuretics not helping, if that is most common diuretic we are using is furosemide. If that is not giving us benefit, then we think of that there is diuretic resistance, and we start with metolazone. If that is also not helping, patient still going in heart failure and volume overload, then the ultimate goal is ultrafiltration. So thank you so much.
Thank you, Dr. Akash. Good morning, senior faculty members, innovators, chairperson, and my colleagues. My name is Hemant, and today I'm going to talk about acute kidney injury and liver dysfunction. Whenever you think about acute kidney injury and liver disease, first we have to think, keep these three pictures in mind. First is liver cirrhosis, second picture shows spasmodic circulation, and third picture renal perfusion. So what happens in cirrhotic liver? There will be resistance and sinusoid level resulting in portal hypertension, which results in increased vasodilator secretion, resulting in spasmodic venous congestion. Spasmodic venous congestion, which further results in arterial underfilling and decreased effective blood circulation, which further results in renal vasoconstriction, decreased renal perfusion, and there will be acute kidney injury in liver disease. Keeping this basic principle in mind, the causes of acute kidney injury and liver disease can be simply classified into three causes, three types. Acute kidney injury is specific to liver disease, which include hepatorenal syndrome, bulimic nephropathy. Acute kidney injury non-specific to liver disease, which are acute renal AKI, drug-induced acute kidney injury, and renal venous congestion, and immune-mediated acute kidney injury, which is seen in hepatitis B or C-related glomerulonephritis. Moving on to hepatorenal syndrome. Hepatorenal syndrome is a disorder of hemodynamics and altered renal perfusion, and is actually a diagnosis of exclusion. The diagnostic criteria of hepatorenal syndrome include renal and liver diagnostic criteria. Liver criteria include cirrhosis with patients with cirrhosis with ascites or acute chronic liver failure. Kidney criteria include rise in serum creatinine more than 0.3 mg per dl within 48 hours, or more than 50% rise in serum creatinine from baseline within the 7 days. And there should be absence of renal parenchymal disease, which include proteinuria more than 500 mg per day, no hematuria, and there should be no abnormal renal ultrasound. And there should be no current or recurrent use of nephrotoxic drugs, which include NSAIDs, aminoglycosides, and there should be no improvement in serum creatinine with 2 consecutive days of diuretic withdrawal, along with plasma volume expansion with IV albumin. And there should be absence of shock. Hepatorenal syndrome is of 2 types: HRS, which is acute kidney injury, HRS non-acute kidney injury. HRS acute kidney injury, there will be rapid rise of serum creatinine more than 0.3 mg per dl within the first 48 hours. And HRS non-acute kidney injury occurs when the pathophysiology of hepatorenal syndrome is not reversed. There will be the renal injury persists. If the renal injury persists for more than 1 month, it is called HRS non-acute kidney injury. HRS non-AKI is also classified into 2 types: HRS acute kidney disease, where the renal injury persists for more than 1 month, but within less than for less than 3 months. And where there is GFR will be less than 60. And HRS chronic kidney disease where the renal injury persists for more than 3 months. Pathophysiology of HRS, hallmarks of renal vasoconstriction and splanchnic vasodilatation, where in cirrhosis, because of portal hypertension, there is splanchnic vasodilatation and arterial alveolar filling, and increase of renin, aldosterone, and RAS activation, and sympathetic stimulation, which further results in vasoconstriction, renal vasoconstriction, resulting in increased renal perfusion, further leading to hepatorenal syndrome. So, what to do when a patient presents in hepatorenal syndrome? As it is a disorder of hemodynamics, the two major hallmarks, splanchnic vasodilatation and renal vasoconstriction, we have to correct these two parameters. First, we have to give volume expansion with IV albumin, which corrects renal vasoconstriction, and then we have to start vasopressor support with serlipresin, noradrenaline, or apiodate plus midodrine combination. The prognosis of a patient who develops hepatorenal syndrome after in a cirrhotic patient is 38% within the first year, and liver transplant is the only definitive management. Post transplant, there is a renal recovery rate of 58 to 76%. Moving on, other causes of AKI in liver disease, the most common cause is renal AKI. As cirrhotic patients will be on diuretics and laxatives for management of ascites and hepatic encephalopathy. There will be overdiuresis and diarrhea, which again manifests in hypovolemia and renal AKI. Management is by volume resuscitation with the point of care ultrasound guided volume resuscitation, where we will see intravenous camera diameter and give volume resuscitation with IV albumin. And cirrhotic patients will have acute variceal bleeding, which again presents in hypovolemic shock and develop acute kidney injury. Management is with variceal banding and resuscitation with blood products. After discussing with these common causes, the most some uncommon causes include renal venous congestion, which occurs in patients with tense ascites and congestive cardiac failure. Here in cirrhotics, there will be cirrhotic cardiomyopathy and portopulmonary hypertension, which results in renal venous congestion, and the management is with large volume paracentesis. The cholemic nephropathy. This is a condition which is actually seen in cholestasis, where when bilirubin is usually more than 20 mg per dl, there will be intratubular bile gas formation, accumulation, and there will be tubular dysfunction and acute tubular necrosis, further leading to renal injury. Usually seen in cholangiocarcinomas, acute liver injury, and drug-induced liver injuries, and obstructive jaundice. Management is by treating the underlying cause and plasma exchange to reduce serum bleeding. There are immune complex mediated glomerulonephritis, usually seen in hepatitis C or B-related infections. Hepatitis C causes membranoproliferative glomerulonephritis, and hepatitis B causes membranous or membranoproliferative glomerulonephritis, where we have to manage patients with antivirals and plasma exchange and patients who already end up in pyrethroemia in both conditions. So, how to approach a patient with renal dysfunction in liver disease? First, we have to rule out drug-induced causes, and we have to assess point of care ultrasound and inferior vena cava diameter, urine examination, urine sodium, and urine microscopy. If urine sodium is less than 20 and IVC diameter is less than 18, we have to give volume resuscitation with IV albumin. If there is improvement in renal function, then it is probably due to renal AKI. And if there is no improvement in renal function with volume expansion, we have to start vasopressor support with serlipresin or noradrenaline or apiodate with midodrine. If there is improvement in kidney function, then we can diagnose the case as hepatorenal syndrome. And if the urine sodium is more than 20 or IVC is normal and urine protein showing any abnormal CAS, axial granular CAS or blood in the urine, we have to rule out causes of ischemic or toxic acute tubular injury or glomerulonephritis, and we have to treat the underlying cause. Thank you very much. Now I would like to call Dr. Tushar.
Good morning, Emeritus Chairperson, respected faculty members, and my dear colleagues. I thank Dr. Hemant for previous talk. Now I'll be taking up obstructive uropathy as a cause of AKI. So any obstruction in the urinary system, bilateral, if it occurs in the upper urinary tract or if it happens in the lower urinary tract, can lead to increased intratubular pressure, decreased GFR, thereby leading to renal dysfunction, and if untreated, it can lead to permanent renal damage. There are various causes that can lead to obstructive uropathy, consequently leading to acute kidney injury. The most commonly encountered being any calculous diseases present in bilateral kidneys or bilateral ureters, any stenosis of the ureters, any prostatic hyperplasia, prostatic carcinoma leading to obstruction of the lower urinary tracts, any tumors if present in the bilateral ureters, or any bladder malignancies obstructing bilateral vesicular junctions, or any stricture of the urethra or metal stenosis can land up the patient in obstructive uropathy, consequently leading to acute kidney injury. The various risk factors that can lead to obstructive uropathy are elderly men where prostatic enlargement is fairly common, any history of kidney stones, any history of bladder or pelvic malignancies, any condition leading to neurogenic bladder, or any chronic urinary tract infections. Now, how to identify a patient who has presented to us with obstructive uropathy? The patient may present with bilateral flank pain or colicky abdominal pain, any history of blood in urine, any history of lower urinary tract symptoms, which may include storage symptoms or voiding symptoms. Storage symptoms as in increased frequency of micturition. Patient may complain of urgency, increased frequency of passing urine in night, that is nocturia, or incomplete bladder emptying. Or patient may complain of voiding symptoms, that is post stream of urine, intermittency, or hesitancy. Patient may complain of acute retention of urine, that is inability to pass urine over the past few hours. Patient may present to us with decreased urine output, that is either patient may have oliguria or anuria, that is incomplete cessation of urine. Or patient may complain of systemic signs of uremia, that is nausea, vomiting, or confusion. Now, how to proceed in such a patient? In any case of suspected AKI, we first have to do an ultrasound of kidney urinary bladder system, and if there is any evidence of hydronephrosis, hydroureteronephrosis, without bladder distension, we can establish that patient is having AKI because of an obstructive uropathy. For that, an immediate management is immediately required. For any obstruction of the lower urinary tract, we have to do a urethral catheterization or a suprapubic catheter insertion for bladder outlet obstruction. In cases of upper urinary tract obstruction, where patient presented was with hydroureteronephrosis, we may need to proceed with ureteral stenting or nephroscopy insertion for bilateral obstructions. Now, after immediate management has been done, to prevent any recurrence of the event, definitive management is mandated so as to avoid any further recurrence of the same event. Depending upon the cause, the management is then done. Obstructive uropathy, if it is identified to be because of any calculous disease, we may need to confirm our diagnosis by either an intravenous pyelography or a computer tomography scan. And if confirmed that the obstruction was due to a calculous disease, we may have to proceed with endoscopic, laparoscopic, or an open lithotomy surgeries. In case of uropathy occurring because of any stricture present in the urethra, we have to do a cystourethropy, which can either be a retrograde cystourethrogram or a micturating cystourethrogram, or a cystoscopy may need to have been done. After that, if the diagnosis is confirmed, we may have to proceed with urethroplasties. In case of uropathy occurring because of any prostatic hypertrophy, we confirm a diagnosis by prostatic specific antigen analysis, ultrasonography, and the uroflowmetry. And if the diagnosis is confirmed, we have to proceed with the transurethral or an open prostatectomy procedures. In case of any tumors, we need to confirm our diagnosis by CT or MRIs. And depending upon the site and the stage of the disease, we have to do either a surgical resection, a chemotherapy, radiotherapy, or a hormonal therapy. Now, a few of the images for academic interest. This is an ultrasonography scan showing a renal calculus leading to obstruction of the kidney and leading to hydronephrosis. This is a sonography picture showing a benign prostatic hypertrophy leading to a bilateral upper urinary tract obstructions. This is an intravenous pyelography scan showing calculus present in the bilateral kidneys and ureters. And this is an intravenous pyelography scan showing the stenosis of the ureter on the left side. This is a retrograde urethrography showing the urethral stricture that can lead to obstruction in the excretory system, further leading to bilateral obstruction and obstructive uropathy. This is a CT scan showing a malignancy present in the urinary bladder, obstructing the left VOJ, and any such malignancy is present in the bilateral VUG system obstructing the bilateral ureter can lead to an obstructive uropathy. This is a cystoscopy image showing a bladder tumor present near the vesico-ureteric junction. This is the calculus in the urinary bladder obstructing the vesico-urinary junction. And if present bilaterally, it can lead to obstructive uropathy, consequently leading to AKI. Now, the take-home message for this is any case of acute kidney injury requires an early intervention. If early intervention is done, relieving the obstruction, it can lead to full recovery of the kidney function. And if due to some reason intervention is not taken up timely, it can result in permanent renal damage or chronic kidney disease, and that may be cumbersome to treat. Thank you. Now I'd like to invite Dr. Abhiral.
I think in your list of causes, maybe we should also include locally advanced clear cervix. It will bring
Yes,
to
sir.
the bladder base.
Yes, sir, of course.
It's a common one.
Yes, sir, of course. Thank you.
I would like to continue the talk. So I will be discussing the topics contrast issued AK and the management of AK and dialysis for AK. So first of all, coming to contrast extruded AK. So we are all used to seeing patients undergoing contrast procedures, and many of you might also be used to by default getting a reference done whenever the creatinine is above some fixed value that we have in our mind, let's say 1.4 or 1.3. So how much is the actual risk and how much is what can we do to mitigate it is what we'll be discussing today. So how are we going to define it? So essentially the criteria is slightly different. A rise of 0.5 or 25% rise in creatinine over the previous value, and it would typically be at 48 to 72 hours after the contrast exposure, and the peak effect is seen at 3 to 5 days. So just one day later, if the patient is normal, that cannot be neglected. So the third point is the most important one. We must make sure that there are no other causes for acute kidney injury. Typically, a patient who is going to undergo a contrast procedure is going to have multiple factors for kidney injury. For example, a patient of cardiogenic shock not maintaining systolic BP of even 80. You should not be thinking contrast as the first cause. So what are the risk factors? So in what patient should we actually be vigilant about the contrast extruded AK? So of course, if you will notice, most of these causes are the same as the risk factors for AK, and what confers the highest risk is when the patient is is already having acute kidney injury or is a known CKD, typically with GFR less than 30. If any patient who is having an acute cardiac insult, and of course post-renal transplant patients, and any patient who is undergoing an arterial procedure is more likely to get a contrast-extruded AK. So there are many factors that we can actually modify, such as the volume status. We can limit the volume, so it would be 30 ml for the diagnostic procedures and 100 ml for the interventional procedures. And the hypoalbuminemia and drugs, like for example, you would like to discontinue the drugs typically at 48 hours before the procedure if it's feasible. And of course, a patient with severe shock, intra-aortic balloon pump. So now coming to prevention, what all specific interventions can we do? So what I would like to emphasize on what doesn't work. Sodium bicarbonate, unless it's indicated for other causes, it is not going to help with the contrast extruded AK. N-acetylcysteine, although widely prescribed, does not work. There is no evidence in the last 15 years that it is going to work. Hemodialysis. Now this might be controversial. So actually, hemodialysis does remove the contrast because we are using small molecular weight contrast. It does remove, but that doesn't actually help. So we do have many patients who we are obsessing about getting them dialyzed immediately after the contrast. That doesn't actually help. Even though contrast removes the dialysis, it is postulated that whatever contrast has been given, the damage already has occurred in the first few minutes if it is going to happen. So what does work at present is only two things. First of all is giving isotonic IV fluids. Traditionally NS has been given, but RL will also work. And use of low or iso-osmolar contrast. These are the only two measures that have been reliably shown to confer an advantage. So going ahead, so the high osmolar contrast we may not have seen. So what we are commonly using are the low osmolar contrast. Specifically, we have iohexol with the brand name Omnipac. It is what we are commonly using. And the iso-osmolar contrast, iodexanol, available as the brand name Visipac. So how much fluids should be given if we are trying to mitigate? So who is going to receive it? So
any patient who is having a risk factor, but most significantly, any patient who is having renal dysfunction is a particular patient who is going to benefit the most. So we must also see whether that patient is even going to tolerate fluids. If he is already not making urine, if he is already having very severe pulmonary edema, of course we are not going to give them fluids. So there have been various protocols. So I have just included two of the simplest ones. So first one is for patients who are admitted. So for 6 to 12 hours pre and post the procedure, we would give them around 1 ml per kg per hour of fluid. And for OPD patients, if they have the risk factors, then we will give them 3 ml per kg over 1 hour pre the procedure and 6 ml per kg over 2 to 6 hours post the procedure. Again, this is only for at-risk patient. Everybody is not going to require this. So this is how we are going to approach it. So any patient who is having a risk factor. So first of all, we have to do the risk stratification. So is there any other reasonable option? If there is no other option but to proceed with the contrast study, we would do it no matter the fear for AKI. So we are not going to risk the patient dying of some other cause. Even if contrast-induced AKI does occur, it is usually mild. It will typically require no intervention, and it is very rarely going to require dialysis, and even only in the rarest of cases is it going to cause chronic kidney disease. So if you have no other test or intervention which is going to give you comparable results, you will proceed with the contrast study no matter the risk of the acute kidney injury. And of course, we would like to go for the risk mitigation as far as possible. If we can give fluids, we will do that. And then we'll go for the isosmolar, low osmolar contrast, try to limit the volume. We'll discontinue the drugs, and if a patient was at risk, we would like to monitor it after the creatinine, at least one value after 2 to 3 days. So, and unfortunately, this is not always done, and there we have seen patients referred from other centers who didn't undergo a coronary angiography because their creatinine was some value of 2. So, creatinine, even if he does AKI, the maximum he's going to get is dialysis. But if coronary angiography is not, then he might actually die of cardiac disease. So there we should not shy about just not causing complications. We have to weigh the risk and the benefit there. So there has been only one promising drug in the last 20 years. So and that has actually come just 4 months back. So they have tried inorganic nitrate. So if you see, we don't use the term contrast-induced nephropathy anymore. But unfortunately, this trial is from the cardiology group, so they have used that term. So what they have done, they have taken the patient who typically gets the highest risk. They have taken acute coronary syndrome patients who are undergoing angiography procedures, and they have seen. So they took 640 patients. They have given inorganic nitrates to them and seen the results. So this has shown promise, but this has been only one single study. So and long-term data is not there. So only 1 year study has been done. So if we do more, this might be what we will need to look out for in the future. Otherwise, we just have IV fluids and using a low osmolar contrast.
So what do you mean by inorganic nitrates? Like some people?
So they are using potassium nitrate actually. That's not actually available with us.
How does it differ from your usual nitrates? You have ISMN, ISDN are available. Are they organic nitrates? I thought they were also inorganic.
They have specifically used one potassium containing salt.
Justification being why only potassium nitrate and not the other nitrates?
So they had that, but they also want to ensure that it doesn't cause any hemodynamic that is seen with our drugs. The ones we use, like typically even with chest pain, we would typically not use them in higher doses. So
I didn't hear anything from you regarding the use of, say, contrast enhanced MRI imaging. Which are the MR contrast safer than the IOPAC and other?
So yes, sir. We have mainly talked about the iodine contrast. This doesn't apply always to MRI contrast. So they have gadolinium containing contrast. So in them, the overall incidence is quite lower, but CKD patients who are going to undergo, it is not safe. Although it's rare, we can get a late systemic complication, nephrogenic systemic fibrosis. That is not very commonly seen, but that is unfortunately irreversible. There can be no treatment for that. So it is not like contrast. Contrast with MRI is somewhat safer. We would still go with a CT scan in that case. That would at least modifiable. So I would just like to end this part with two articles that I would suggest to read. The second one is the 2022 consensus statement from the American College of Radiology and the National Kidney Foundation. So it details the various drugs and the various data about the contrast-associated AKI. And second, a new thing that is coming up right now is the contrast-associated acute kidney injury. So with the newer low volume contrast, it's postulated it simply may not exist. So we'll see more in as the pathophysiology studied in detail in the future.
So 2017 के बाद there has been no update.
So that is
The
2000.
field of contrast, IV contrast is greatly expanded.
There has not been any like changing data that so this the statement is for 22. That is for the previous article. There has been no such article stating this point actually. So we'll just proceed with the management of.
So I think I have a few questions because it's vital for us in oncology to get imaging done, and many times we are stuck with a creatinine of 1.8. So is there an absolute cutoff of serum creatinine or creatinine clearance where it's an absolute no-no or it's just a relative risk?
So depends on how badly we need to do it. There is no cutoff. Even if the creatinine is 10, we will take consent of dialysis and we'll give the contrast. We'll never ever hold an essential study for the sake of the kidney. It is easily replaceable in the short term. Easily replaceable in the short term. Yes, we'll dialyze the patient. But some other disease may not be curable. So we would like to proceed with the management of AKI. So I would like to just cover the very basic principles. So mainstay we must realize, everyone must realize that you don't treat AKI. We cannot treat AKI. There is no treatment for AKI per se. So whatever treatment is going to be there is if we can identify the cause. If it's a glomerulonephritis, we'll give the immunosuppression. If it's a hypovolemia, we'll give fluids. If it's due to hemorrhage, we'll give blood. But we cannot treat AKI. So there is nothing we can do if the patient is having no other correctable features. Maximum we can do is dialysis. So what is very important is that we prevent it. So most importantly, use of nephrotoxic drugs. So a patient with no pain is in the ICU is probably not going to require thrice daily NSAIDs. So that is one of the most frequent references that we see in the ICU is patients getting NSAIDs for no reason. And if patient has AKI, I mean there are reasonable alternatives to giving NSAIDs. So we can also be a little bit vigilant. We will try to see at least in the patient who is at risk. We would try our best to avoid these drugs. So and most important thing in most of the patients that are coming to us in an emergency is going to be a rigorous volume assessment and maintenance of a fluid balance. So for us, the easy to learn method is learning the point of view ultrasound. So if we know how to assess three things, first is the inferior vena cava diameter assessment, the basic cardiac ultrasound, and the lung ultrasound. So we can integrate these three into the false protocol, which we'll discuss. And of course, presently the gold standard would be to use a venous access ultrasound. So although that is cumbersome to do. So we'll just discuss in brief the false protocol. So what does it stand for? Fluid assessment limited by lung sonography. So as simple as that. So we are going to give fluids and we'll see if lungs start getting fluids. When you start getting fluids in the lungs, you will stop. So step one would be, we'll just rule out obstructive shock. So depending on so this is the way to approach it, but of course you can modify it according to the patient. So if you have a patient coming, so you'll do a basic, first step would be doing a basic cardiac ultrasound and basic lung ultrasound. So you will find out if there is a pericardial tamponade. Like in this case, if you see this patient, so this is actually from my first, this is a patient of CKD who was on dialysis. And he was going into shock and no measures were working, shock and breathlessness was not improving. So just putting the probe in this case is going to give us the diagnosis. And there is nothing we can do by drugs in this case. This will require pericardiocentesis. And this patient's life was actually saved by the pericardiocentesis and he underwent a renal transplant a few months later. So we'll pick up the pericardial tamponade, we can pick up the RV dilatation if it's a pulmonary embolism. And in the lungs, we can pick up the pneumothorax. And it is very important for us to know that all these studies can be done with one single probe. The probe that is used for echo can do all of these studies. So then going ahead, so if we have ruled out obstructive shock, we'll go and see for the cardiogenic shock. If we have found a abnormality like a poor ejection fraction on the echo, And then we'll go see in the lungs. If the patient has a cardiac abnormality and you see fluids in the lungs, it is going to be cardiogenic shock. Giving fluids will not help. So this is what fluid looks like. People who are using lung ultrasound will identify this. This is called as a B profile. You see these vertical lines. So these basically indicate non-aerated lungs. So there are three differential: consolidation, collapse, or fluid in the lungs. So then when you have ruled out these causes in which fluid is not going to work, so then you are thinking of hypovolemic shock. Then of course at this point you start giving fluids, and then when you have given some helicopter fluids and it's not working, or you start getting fluid in the lungs, then at this stage you are thinking of distributing shock, probably septic shock, and in that patient giving more fluids is not going to work, you will need to start inotropes. So this is just what a Vexus scan would look like. So you just, if you have a dilated inferior vena cava, you would do the hepatic portal and renal vein Doppler. You try to find abnormalities in them, and then you can grade the venous excess in the body according to that. But of course, this is not possible to do easily. It requires a lot of time and specialized training.
In your previous question, the previous slide, in the false protocol, there is no place for IVC diameter, IVC variability, which is a very reliable system, sign of systemic congestion. You're only talking of situations where already there is contraindication and fluid is flooded organs. So, I mean, if you were to combine this with an IVC assessment, which is probably simpler than doing an echocardiogram, and you find that your IVC is just 15 millimeters, that the patient is severely hypovolemic. Whereas if you find a 20, 22 or a higher level of IVC and you have a system that is overloaded, you may not really have to go and watch the lungs and see when they are getting flooded and then you stop. You know that you already overloaded.
Sir, actually for using IVC, we would never ever use IVC in isolation unless we have established that the heart is working fine. So this is false protocol is not just for our medical patients. It could be for a patient with trauma. So in that scenario,
in addition to the other components, why not also include IVC assessment in this? That's what I'm saying.
So actually, it's not included in this.
So modify the false. You know what works?
Yes, sir. So this is for generalized for the ED department actually. So they don't, because they don't have serial markers, so they will not use the IVC much. This is for the first assessment. But yes, we do incorporate the IVC with it. So now, so that's a very different and very complicated study, and very few people in India would actually be qualified to do this. Hardly anywhere.
Venous access ultrasound. Are we having this program?
We have, it's done with the abdominal probe, but the reliability is very much subjective. That is the issue with using it. It's very, unless you are very much certified in using it, would be very dangerous to rely on it, because the getting those views requires very significant amount of training. So it's not just like measuring the IVC, getting the portal vein Doppler, getting the hepatic vein Doppler is very difficult.
It is expertise, training, and again, it has to be a favorable anatomy. If you have 15 liters of ascitic fluid in the abdomen, you're never going to be able to see the portal vein and the renal vein. So we often resort to large volume paracentesis, get the abdominal pressure down, and then visualize the vessels. Apart from this, also you do the arterial imaging, you would do the renal artery, RP, or other techniques are the renal artery resistance index, which is normally done for intrarenal vessels. Something we do normally for the liver. I'm not too sure how it would work. Yes, I agree with you that this can only be taken up by somebody who is trained and regularly practicing.
So this is the gold standard.
Ultrasound based, sir, this would be the gold standard.
So gold standard should be something which is a very definitive thing. Over here we have too many variables which actually doesn't fit into the category of being the gold standard.
This is the best marker, I would say.
In terms of non-invasive, sir, if you're doing it at the bedside non-invasive, this would be among the best methods. But if you're doing it in invasive method, then I think flow track and other hemodynamic methods are much more objective, and they are probably the gold standard.
So variability is the issue, reliability is the issue. So that's why we should not take it up lightly unless we have been specifically trained for a long time.
Too much of variability and reliability is the factor which is the distracting factor. It doesn't qualify for being gold standard. That's what I wanted to just say.
So now coming to IV fluids. So this is always a frequent question. कौन सा fluid देना चाहिए. So coming to it, so if you see, I just taken the most common fluids. If you see, for example, let's say we give a liter of D5, so only 83 ml is going to be retained in the intravascular volume after a few hours. So of course, IV fluid, if using D5, is going to be a horrible fluid for resuscitation. 0.45 saline, slightly better, 167. But coming to RN or NS, they are going to give you approximately 250 ml of intravascular volume, and this is why they are going to be the preferred fluid for giving. Even among them, I would argue that RN would be the better fluid. So coming to colloids, sorry, coming to next slide. So coming to colloids, so colloids give you a 1:1 ratio. If you give a liter of colloids, almost all of it is going to be retained in the intravascular compartment. So theoretically, they would be the best fluids. Unfortunately, that has not been the case outside of very specific scenarios such as hepatorenal syndrome or use of albumin in patients with sepsis. So outside of that, because the colloids that were previously used, that hydroxyethyl starch and all, they are very less commonly used now. Much higher than what is in the blood. Usually, if you remember, it would be around 90 to 110. And the osmolarity again 308, again much higher than the plasma. So the problems associated with normal saline are again going to originate from this chloride. This chloride is going to be in excess. This chloride is going to go to, if you remember the juxtaglomerular apparatus and the tubular glomerular feedback, this chloride is going to be sensed by the macula densa, and that way, this chloride itself by itself is going to worsen the glomerular filtration rate. Additionally, we have an obsession with not using using NS in patients who are having hyperkalemia. That NS would correct hyperkalemia. NS doesn't correct hyperkalemia. It is actually the worst fluid for hyperkalemia. This chloride is going to cause renal dysfunction. NS again, if you go and study it in detail, is going to have a non-anion gap metabolic acidosis. That is always going to worsen the hyperkalemia. Coming to RL, the first hate given to RL is because it contains potassium. We cannot give it in a patient who is having hyperkalemia. The potassium in RL is only 4. So first of all, if you give 1 liter, you are giving only 4. So what is the usual correction dose? Whenever we are trying to give IV potassium, it is something like 20 or 40 or 60, something like that. So what is 4 going to do? Absolutely nothing. And again, we are not giving just 4 milliequivalents of potassium. We are giving 4 milliequivalents per liter. So if you have a hyperkalemia with a potassium, let's say 6, and you are giving a fluid that is containing only 4, how is that going to worsen the hyperkalemia? It can only correct it. Additionally, we keep forgetting this contains lactate. So if your liver is working, this lactate is going to get metabolized to bicarbonate. That is going to improve your acidosis, and that is going to improve your hyperkalemia. So not only is RL safe in hyperkalemia, it is actually the preferred fluid. And I am saying RL to simplify things, but essentially the other balanced crystalloids would work in a similar way. They are for specific scenarios, they could be better, but RL works for most patients. But you could also use plasma light or stereofunding. If you notice, again, they have also a similar profile to ringus lactate. They all contain potassium, and they all have some sort of buffer. If you see, it's acetate in the plasma light and in stereofunding. So coming to it, so and then again, what are the issues with RL? So first is compatibility. RL contains calcium, so when most of the drugs that we can give with NS, we cannot give with RL. So that is one limitation in this case. And we'll just go and discuss where we would actually use NS. So what we have already discussed is crystalloids are better than colloids. Balanced crystalloids such as RL or stereofunding plasma light are going to be better for most patients. Where would you prefer NS? So it is a patient who is having a raised intracranial pressure, they are having that higher osmolarity is going to help. If a patient you are trying to correct hyponatremia by giving fluids, if it's hypovolemic hyponatremia person. So in liver failure, if you only have RL and NS, so theoretically the lactate might not get metabolized because the liver is not working. But again, emphasizing it doesn't apply to every case. So in a patient with sepsis who is having some 3 or 4 lactate, it's not like you cannot give RL. You are not giving lactic acid. RL is containing sodium lactate, that is not going to worsen. And again, that patient in sepsis who is having some raised lactate is not having lactic acidosis per se as the cause. That is the effect of the poor tissue perfusion. So you can use RL there. And patient, of course, where you are having metabolic alkalosis itself. So there, theoretically, NS could be a better fluid. So how much fluid should we be given? So this is a very frequent source of contention. So when you have decided that fluids are to be given, you will not hesitate unless you have some reason. So giving a patient, you are thinking hypovolemia, you are giving 200 fluids is simply not going to work. So the target of fluid resuscitation in the first 3 hours is going to vary, but a general common number given is 30 ml per kg, that is as per the surviving sepsis guidelines. Of course, you have to decide where it's appropriate for your patient. So if cardiac failure is there, renal failure is there, liver failure is there, you would not give such a higher dose, you would give smaller aliquots and you would see how the situation is improving. And then the maintenance fluid would typically be given, you will give just enough to maintain the urine output above 1 to 1.5 liters ml per kg per hour. So to just summarize how to decide which fluids, resuscitation and maintenance. This should be the general takeaway from this part of the talk. So coming to deciding for dialysis, so we are all aware with the very classic mnemonic AEIOU, so a very severe acid. So we must think that by themselves they are going to be relative indications. When they are refractory to medical management, they are going to be absolute indications. So patients with having metabolic acidosis, severe hyperkalemia or rapidly worsening hyperkalemia. So a potassium of 6 that has been 6 for the last 3 months in a CKD patient is not very likely to immediately cause arrhythmia. But a potassium of 5.3 that has risen from 3.2 in the last 6 hours or 8 hours is a very severe hyperkalemia. Again, ingestions until certain drugs might be dialysable, so we might do dialysis for that purpose. Any patient who's having refractory volume overload or pulmonary edema, any patient who's having uremic symptoms, so urea may not be the cause, it is merely an indicator of the state and there is no absolute cutoff, this much urea must be there, but usually it would be above 100. And we must make sure that there are no other causes that are explaining the uremic symptom. So there is also the concept of renal support we are not discussing. So that is when we are dialysing even before the complications arise. So when do we dialyze the patients? If there is a life-threatening indication, we will urgently initiate the dialysis. And if there is no specific indication, so it does not improve survival. So dialyzing early for most patients does not work. And additionally, if we are going to do a high-risk dialysis, such as in a patient who is on high inotropic support, we will only do it when there is a life-threatening indication. To remove 500 ml of fluid, we are not going to start dialysis in a patient who is on a NORAD of 10. So coming to the last part, just a brief overview of the various diuretic modalities for acute kidney injury. So once we have decided that we are going to do a dialysis, so there are 4 options essentially that we are going to have. First is your intermittent hemodialysis, your conventional hemodialysis. Second is the continuous renal replacement therapy, CRRT. And then there is a hybrid therapy such as SLED, sustained low efficiency dialysis, and last peritoneal dialysis. So the intermittent hemodialysis is using the conventional dialysis machine that we are using for CKD patients. So we are doing primarily a diffusive treatment. So diffusive treatment mainly removes the smaller molecules. So this will remove potassium, this will remove urea, this will remove creatinine. And you can remove some fluid by ultrafiltration. So we typically do it for 3 to 5 hours. We can do it, we usually do it 3 times per week. So CRRT is essentially a dialysis extracorporeal blood purification which we are doing for 24 hours or a day, or at least we are trying to do it for 24 hours. Of course, there is going to be interruptions. Patient is going to undergo another procedure. There is going to be change of the filter, change of the fluid. So that is our intention is to use it for 24 hours a day. So what is the advantage? So it is essentially the main advantage is gained by the slow removal. It works kind of like a kidney. So that is why there might be improved outputs. There is slow removal and we can decide hour and hour basis how much fluid do we want to remove. And so this is what the CRRT machine looks like. These are the settings. So you have got your anticoagulant, your blood flow, fluid removal, the dialysate replacement and the calcium. We will not get into the detail, but people who are seeing patients on dialysis must be aware of the basic orders that we are using. So now the question is mainly of decision making. Where do you use CRRT? Where do you use intermittent hemodialysis? So in any case who is hemodynamically unstable, CRRT would be referred. In a patient where there is raised ICP, such as any patient who is having a brain trauma or acute liver failure, CRRT would be better. So any patient where you want less bleeding, so because intermittent hemodialysis gives us less bleeding, less clotting, it's a short duration procedure and you can do it without giving any anticoagulation also. So there it would be preferred. any patient who is going to have sepsis or MODS or ARDS, doing CRRT would be preferred. So it's very important that CRRT gives us one additional advantage over conventional dialysis. So what we are doing is hemodiafiltration. So this is dialysis plus hemofiltration. Hemofiltration also removes middle molecules, and most of our mediators of sepsis and inflammation, our cytokines, TNF and all, they are all going to be middle molecules. So because CRRT removes them, it gives us an additional advantage over using plain dialysis. So that is how there is arguably better renal recovery and survival, but of course the cost is going to be 20 times higher than intermittent hemodialysis, that being the main limitation. So coming to SLED, so it's essentially we are using the same conventional HD machine, the higher end HD machines. So we are doing the same dialysis with a slower speed. So our blood flow and our dialysis flow is going to be approximately half that we use in conventional dialysis, but our dialysis duration is going to be longer. So we are trying to use the same HD machine and we are trying to emulate the CRRT principles. So that is essentially what SLED is. So it is usually diffusive. We can also add hemofiltration to it, which we are presently trying to do. So that way you will also get middle molecule clearance. Coming to peritoneal dialysis, so essentially we are using the peritoneal membrane as the dialyzer in this case, and we are going to give a high osmolarity fluid such as glucose, which is going to drive that dialysis across the peritoneal membrane. So it was very common, now it's not very much preferred because of the advent of SLED and CRRT, but it works, especially if you are using it with a cycler device. We can give higher dose of clearance, and there have been some trials which show that it can give approximately the same level of clearance as CRRT with a much lower cost. And of course, a very significant advantage is that doing dialysis, such as in a case of natural disaster or in case of COVID, where we are limited by the number of machines, using something like peritoneal dialysis in that case could be very useful. I'd like to end our talk here. So we have discussed in brief about the contrast-sexual decay. We have discussed about the fluids and 30 seconds.
You did a